I think you have to click on the got it, Purvi.
Did not get any message, ma'am. Am I not visible, ma'am?
You are visible. You are visible. You have to just click on that got it. That's coming in between the slide. Yeah, okay. No issue.
Is it coming now?
No. Okay, we are going on live.
Visible?
Yes. Good evening, everyone. Welcome to the Higgs Journal Club for this month of April. Today, we will be speaking about regard VAP trial, that is the individualized short course antibiotic treatment versus the usual long course treatment for ventilator associated pneumonia. It's a multi-center trial, and today we have Dr. Urvi Bhupendra Patel from Zydus Hospital, Ahmedabad, to take us through this trial. We have our senior consultant, critical care and chest specialist from the same hospital, Dr. Manoj Singh sir, as her guide. I welcome Dr. Srinivas sir for the moderation. Over to you, Dr. Urvi.
Good evening. Good evening, everybody. Good evening to all the respected mentors, my guide, for giving me this opportunity to present this regard VAP trial. So it's my pleasure to present this to you all today in this scorching heat of this Saturday. So I will be presenting the regard VAP trial, which is an individualized short course antibiotic treatment versus usual course treatment for the ventilator associated pneumonia trial. This trial was basically conducted by Dr. Yin Mo, Suchat Bopan, Andrew Yunke, who were the primary investigators on behalf of the regard VAP trial. And this trial was basically published online in this year, January 2022, in the Lancet publications. So basically, the background on presentation of this trial was the incidences of ventilator-associated pneumonias are highly prevalent in our ICU setups, and they have been linked to excessive antibiotic usage in our setup, also with the increased antimicrobial resistance and the probability of prolonged hospitalization, long ICU stays, increased mortality, as well as the long durations of the antibiotic. Though according to the recent guidelines, they have told to use the antibiotic for approximately 7 to 8 days, but still that's not being used practically. So this reducing antibiotic treatment duration for the ventilator-associated pneumonia, that is the REGARD trial, it was basically to evaluate this clinical effect of the individualized short course antibiotic versus the usual short course, usual long course, which is being used in our hospitals to treat the VAP pneumonias. So this study was done from May 2018 to 2022 in almost 39 ICUs from Nepal, Singapore, and Thailand. Those are the low middle income countries, just like ours. So basically, the participants in this study this study was basically a randomized controlled trial, which was being conducted as a single blind hierarchical non-inferiority superiority trial from almost 39 ICUs, and these participants were randomly allocated into individualized short course. They defined the short course for this trial as less than or equal to 7 days of treatment and as short as 3 to 5 days, or to the usual care cohort group, which was involving the treatment for more than or equal to 8 days, or we can say it was almost involving the treatment up to 14 days or more. And the treatment part were primarily decided by the clinicians. So the blinding was basically partials, and the clinicians were not included in the blinding. So this is just a short overview of this trial, which was being conducted. We'll just go into the details. So we can almost see that there was a cross-sectional study done over 1,417 ICUs that the prevalence of respiratory tract infection was almost 64%, which was mostly due to the nosocomial infections ongoing in the ICUs. So if we can estimate the overall mortality in the patients with VAP, it was ranging from almost 20 to 50% and as high as 94% in low to middle income countries. So the VAP has almost led to the lengthening of the ICU stay by 7.6 to 11.5 days and hospitalization by almost 11.5 to 13 days. And it has also led to increase in the cost to the patients. So basically, this trial was conducted to see if the short course was non-inferior to the usual care group. So the population which was included in this regard web trial was mostly the adults who were more than or equal to 18 years, suffering from the ventilator-associated pneumonia, and the criteria for deciding for labeling the patients with ventilator-associated pneumonia were usually the ones defined by the U.S. Centers for the CDC of U.S. NHSN criteria for VAP. Mechanically ventilated patients more than or equal to 48 hours, those who were being administered the antibiotics either on the basis of culture, and if the cultures were negative, then empirical antibiotics were given based on the local hospital antibiograms, which were reported by the respective laboratories of the concerned hospitals, as well as the prevailing local antibiograms of the concerned ICUs. And the patients were assessed until the fever resolution for 48 hours, or the patient had achieved hemodynamic stability, and then they were randomly assigned 1:1 ratio to the short course treatment or to the usual care group, and the cohorts were permitted the blocks of variables almost 8, 10, and 12. So the exclusion criteria for the REGARD trial was those who had poor likelihood of survival, which was defined by the SOFA score of more than 11 points. Those who were immunocompromised, like the HIV patients whose CD4 count was less than 200 cells per millimeter cube. Corticosteroid usage was more than 0.5 milligram per kg per day for almost a month, or who were on chemotherapy in the past 3 months, or who had a solid organ or hematopoietic stem cell transplant, and who had concurrent infections which were requiring a long-term antibiotic treatment, usually more than 7 days, excluding those who were on the anti-tubercular treatment, animal treatment, antibiotic meant for any kind of chronic usage, like in the chronic infections or those suffering from COPD. So those patients were excluded in this trial. So what was the fitness criteria to stop the antibiotic in this trial? So the fitness criteria was the body temperature of lower than 38.3 degrees Celsius, which was usually measured orally or rectally, that is a poor body temperature, or lower than 38 degrees Celsius, that is the axillary temperature, for 48 hours. And the patient had achieved hemodynamically stability in the form his blood pressure, that is a systolic blood pressure, was more than or equal to 90 millimeter of mercury without any inotropic support, or did not require the inotropic support to maintain their systolic blood pressure. This is just a concept diagram for this study that almost in the 3 countries, almost 10,979 ICU admissions were being screened, and out of them, the one who satisfied the NHSN VAP criteria by the US CDC were almost 461, and those 461 were randomly assigned to the cohort group, either in the short course group or either in the usual care group, and almost both had similar number of patients, like 232 patients were assigned the short course group and 229 were assigned the usual care group. And then they had followed those group for almost 60 days, and they were both included in the intention to treat group, and then analyzed if they did not had any adherence to the ongoing treatment, then they were excluded according to the per protocol analysis criteria, and then included in this study. So in this study, they have used both intention to treat and per protocol patient for the analysis. So this is the details which were given from the study, that is from both the short course group and the usual care group. The median age of enrollment in this studies was almost 63 years of age, almost equivalent in both the groups, but they had more males as compared to female, which is expected from low middle income Asian countries. And they had more number of patients from Thailand, both in the short course and usual care group. Um, Actually, 4 countries were assigned. Even Brazil was taken, but Brazil did not give major contributions to this trial, so they did not consider the result from Brazil. And the residents who were admitted to the ICU were both received from the community as well as those who were transferred from some other healthcare facility were also involved. And they also studied the patients according to the comorbidities, which was they used the Charlson comorbidity score, which was almost similar in both the groups. And the majority of comorbid condition found in the patient was diabetes, followed by chronic kidney disease and congestive heart failure. And the SOFA score for these patients was almost 6, on an average 4 to 8 for the interquarantile range. And they included the VAP onset from the 0 days for the for starting the antibiotic. So majority of the patients who were being involved were from the surgical group, almost 160 and 160 in the short course group and 156 in the usual care group. And the reason for the intubation in most of the patients was respiratory failure, followed by any kind of neurological failure, followed by the trauma or airway obstruction, which was followed by the post-operative care group, and then less likely the cardiac failure or the metabolic acidosis. And the most population had carbapenem resistance gram-negative bacilli growing in their respiratory samples during the VAP period, where included almost 76 people, almost 33% population was having this CRE resistant organisms. And they have also studied the vital signs of the patients both during the onset of the VAP and then during the randomization. So during the onset of VAP, the patient had requirement of the inotroph support, and their SpO2 FiO2 ratio was almost 225 round in both the groups. And when they were on the day of randomization, there was decrease in the inotroph requirement almost to 5%, and the SpO2 FiO2 ratio was 250. So this was the analysis of the population. So the intervention was the short course antibiotic, and they had compared it with the usual care group. So this is the diagram. So then the outcome was analyzed for the population. So the primary outcome was decided based on the 60 days group and on the pneumonia recurrence. Most of the study took into account the 20-day mortality for the patients, but in this study, they had included 60 days mortality so that they don't leave any patients who were on the longer ICU stay for the follow-up. And the inferiority was met in the primary analysis only, and the secondary analysis for superiority was also performed. So almost 461 patients were randomly assigned to the individualized short course group, and in the per protocol analysis, after exclusion of the non-adherent group, in the short course group there are 211 patients, and in the short usual care group there were 224 patients. So almost 10% of patients did not adhere to the treatment. So if we go for the intention to treat group, then almost there was a 35% mortality in the study for the short course group and 38% in the usual care group. The pneumonia recurrence was almost similar in both the short course and usual care group, almost 14%. And the primary outcome was 41%, which according to them was comparable to the data available from the non-income, almost similar to the previous studies of the high-income countries. So 41% had if the intention to treat analysis was taken, then the median duration for antibiotic was almost 6 days. Among the usual care group, they were given antibiotic for median duration of 14 days, almost ranging from 10 to 21 days. And the antibiotic side effects, it was lower in the short course group, only 8% versus the usual care group, that is 38%. If we were seeing the intention to treat group, then the absolute risk difference was only 3%, with a confidence interval of 95% ranging from infinity to 5%. If we are seeing secondary outcomes from our study, then at 60 days, almost 169 of 460 patients died, that is 37%, and 81 in the short course group and 88 in the usual care groups. So the mortality was usually attributed to pneumonia. Almost 12% of patients in the short course group and all similar person died due to pneumonia in both the groups. So if we are seeing for the secondary outcome, then the duration of admissions, the duration of mechanical ventilation, the ICU stay, the duration of hospitalization was almost similar in both the groups. Even the readmission was almost similar in both the group, almost 19%. And pneumonia recurrence was also similar in both the groups, around 18%. If we are seeing towards the colonization part, then those who were suffered from any newly colonized organisms or who were infected with the carbapenem resistance gram-negative bacilli after the enrollment to the study was almost similar in both the groups. That they did not find any advantage in the antibiotic resistance. But the only difference they found out was in the side effects, that is the AKI, which was been studied according to the KDIGO guidelines and the latest thing. It was seen that in the short course group it was only 5%, and in the usual care group it was 35%. So this was a major difference they encountered, and even any other side effects was more with the usual care group. So if we see towards the bacterial which were isolated from the VAP indexes during this study, that almost from 320 index episode of VAP, they had isolated 491 bacterial pathogens. So, and rest of the 30% were actually culture negative groups. So in the patients whom there was a culture positivity, they were mostly the gram-negative non-fermenting bacilli which were isolated, like Acinetobacter, Pseudomonas, Enterobacterales, which were carbapenem resistance, and 86% were resistant to the cephalosporin. And they had treated these patients with either colistin-based or polymyxin-based combination. Like almost 41% in the short course group had received this regimen, and 49% in the usual care group. So what are the limitations of this regard VAP trial? So the limitations were most of the patients were from Thailand. The unit level antimicrobial resistance, colonization, or the infection data were not available. Then majority of the patients were the surgical patients. Some of the patients were non-adherent to the allocated antibiotic duration, which probably increased the non-inferiority when the short course strategy was probably inferior. What could we interpret from this regard VAP trial? So basically, individualized short course antibiotic duration guided by the clinical response was non-inferior to the longer treatment duration in terms of 60-day mortality or the pneumonia recurrence, and also had reduced antibiotic side effects and use. But then, so that this short course antibiotic will help in reducing the side effects and antibiotic resistance. And this was what few quotes by the study team, which we can see. Their primary team told that very few trials were done in the previous settings. The rate of pneumonia higher than in the high-income countries, and they were majority driven by the antibiotic prescription, and they were likely to contribute to high prevalence of multi-drug resistance organism, which suggests the benefit of interventions to reduce the antibiotic use in such settings. And they were potentially been using the international antibiotic stewardship guidelines to promote the same. And according to them, they had a set of easily reproducible, simple clinical criteria, like for reducing the antibiotic duration, like the absence of fever and the stabilization of the blood pressure, which I think can be adopted by the low to middle income countries like the other Asian countries, which do not have the facilities for much of the sophisticated blood test like the procalcitonin and all. So in the prior studies, if we are seeing, then the procalcitonin was used to determine the duration of the antibiotics, like the PROACT trial or the PRORATA trial, or they had seen that if we were using the procalcitonin, then the length of stay was lower, the 28-day mortality was lower. But again, there was recurrent risk of infection with the based on the procalcitonin study also. There were few other studies which were done previously for the comparison of short course and long course antibiotics. One which were done by Vogel in 2022, which was being using the beta lactams with the aminoglycosides versus the fluorophenols, 8 day versus 15 days for the late onset VAP. And they had studied the patients since till 90 days, and they did not found much more benefit with the 8 days. And few other studies were done for the same. So what do you all think? Should we consider the short course over the long course for treating the VAP? If you ask me, my take-home message will be the individualized approach for tailoring the antibiotic duration shifts. According to our mindset, it should be treated with the arbitrarily defined durations on which were being studied till now. But from this study, we take home the message that the duration should be tailored according to the patient's responses rather than going on to the one-size-fits-all approach. So over to you, mentors.
Thank you, Dr. Ruby. Manoj sir, I'll take comments from you about this trial, sir.
Yeah, okay. So thank you, Urvi. I think you presented very crisply. To me, I think it is a well-designed trial. I appreciate if the British people who actually designed the trial could have considered India as one of the centers. I don't know why they didn't choose us. Maybe we don't have that much VAP. Probably they would have known that. First of all, comments on the randomization. The randomization days is not very clear. I think, Shri, you should comment on that. They haven't taken 20-day mortality, rather they actually followed for 60 days. I don't know the reason why. And antibiotic protocol was not standardized. Most of them were surgical patients. So here, stopping antibiotics, if the source was already controlled, was a good go ahead. But in medical, sometimes it is difficult to actually stop the antibiotics in 5 to 7 days, even if it is VAP/SSI/sepsis. Also, if you see, we all one data which they give us, patients on the day of randomization were not too sick. Only 17% patients were on inotrope. So I feel, as Dr. Urvi pointed out, whether they're all only colonized or they had an actual VAP is not very sure. Only 13% patients who were needing inotrope on the day of randomization, vis-a-vis their mortality of VAP, I don't know, they have directly attributed this to the VAP as 33%, which is quite high. And on one side, they say the mortality related to pneumonia was only 12%. So probably surgical source control was not addressed. They've not commented on it. Second, the authors go to say that short course is non-inferior. We agree. They try to say that the long course has more incidence of acute kidney injury. But I will take it with a pinch of salt. Probably long course is because the patient is staying long, they are probably more sicker and they need more than what only antibiotics are considered. So probably they succumb due to their own primary illness needing ICU. And also, if you see one of the data given is mean duration of mechanical ventilation was 20 days. So I don't know why they were ventilated for 20 days and they had only VAP, which needed antibiotics for 3 to 5 days, vis-a-vis 7 to 15 days. So there, I think, Dr. Srinivas, I would like you to comment upon this data which has been published. Trial was good, very nicely designed. cohorting was good, the randomization was good. It was a prospective trial, but some data actually makes me think. And again, as Urvi said, most of the patients from Thailand and a surgical ICU. So, are this data a little bit statistics manipulation or what? I'm not too sure. It's a good thought to reduce the duration of antibiotics. We all agree that pneumonia, when it sets in, actually short course may be as good as a long course, because rest will be followed by a good intensive care, a standard of care on ventilator, standard weaning protocols. So I'm okay with antibiotics for a short course. But as far as the trial design is concerned, some of the data which I shared, Srinivas, your comments, please.
Manoj. Um, I have a little different view from what you have on this study. I
Yeah.
agree that the randomization was not very clear, and they did not look at 28-day mortality directly going for 60-day mortality. But the thing we need to look at it is one, the microbiological profile which they have discussed is more or less what we find
True, true.
in
Agreed.
our country. In our country. Second, it is a very pragmatic trial in the sense that they did not use very high-end investigations like a procalcitonin or a bronchoalveolar lavage to prove or disprove a pneumonia. So it can be applicable to most resource-limited. I don't like to use the word low and middle-income countries because even in the rich countries there are resource limitations. There are units which don't have bronchoscope. There are units which don't have hemodynamic monitoring, which they fail to acknowledge. So I would like to say that this is a resource limited setting. In a resource limited setting, this kind of data can be utilized.
Agreed.
Third point is agreed that the the side effects were a little higher, but I am not happy to accept that that was just because they stayed longer. Because whether it was the hemodynamic instability, whether it was the oxygenation, it was comparable in both the groups. If the acute kidney injury was due to a systemic disease for which the patient stayed longer in the ICU, it would have been associated with one of these common causes of acute kidney. If it was not there, I would probably look at it. We don't know the exact distribution of antibiotics which they used for this patient, but I am assuming, given the resistance patterns, polymyx genes, and some of those toxic antibiotics would have been used in these patients. So I would probably look at it as a longer use of these antibiotics probably resulted in a cumulative toxicity, especially renal toxicity. So that is one thing I would see. So my positives from this study are it's a pragmatic trial. It is applicable to low resource limited settings. They've used simple parameters which every hospital can have access to. Three, they have actually showed that you can reduce the morbidity by reducing the side effect of some of the toxic antibiotics without an increase in mortality, without causing harm to the patient or changing the microbiological profile of the ICU by using a shorter course of antibiotics. What are the negatives of the study? How applicable it is to a general intensive care unit, I am not sure. So you need to have surgical patients who are not on steroids, who are not on any chemotherapeutic agents, who don't have structural lung disease for you to apply the results of this study. So a priori, it is creating a huge outlier effect, but it will probably be applicable if you have this subset of patients. It will definitely be. The second negative thing for me for this particular trial is that how do our Indian intensivists react to a change in antibiotics without writing that famous protest story? So you will have you. I mean, it is okay to quote the regard VAP trial and say they used only white cell count. But how many of us will accept this and not do procalcitonin? And if the white cell count is regressing, vasopressors are improving, if the procalcitonin is not improving, how many of us have the courage to actually reduce the antibiotic duration from 7 days to 3 days? This is my concern. That is one negative uh, applicability of this study to our population. I am a little concerned.
Sir, I was thinking like they have used this endpoints like decrease in the temperature and also the vasopressors being stopped. But because this is VAP, maybe they should have used something with the oxygenation parameters, like the PF ratios or something. But to begin with, I think when these patients were actually taken into the study, their PF ratios in the both groups are almost more than 200.
Yeah, that's what I said. They are not two sick patients. And also, in one of the captions, they have written, Srinivas, that the patients were also ventilated in the wards or intermediary settings. That is why their average or length of ventilation was more than what they anticipated during randomization. They must be COPD, I'm not too sure.
What I can understand is their infection control practices are worse than ours. If you look at their VAP rates, their mortality
I know,
rates,
I know. I agree with
so
you.
in a situation where your infection rates are 90%, even if you do one intervention which can actually change the outcome, your results will be fantastic.
Correct,
As
correct.
as a country, I don't think we are that bad. We are not very good, but we are not that bad either. Maybe our VAP rates are about 40 per thousand ventilator days in the worst in a worst sentence and 15 per thousand ventilator days in the good sentence. But we are not reaching 80%, 90%. And our mortality with late onset VAP is not 100%. Navina quoted 100%. So we are not that bad. But having said that, yes, and I mean, it would have been good if Brazilian ICUs also have participated and their data was analyzed because it's also one of the countries where a lot of data related to lower income countries and resource limited ICUs is coming for the last 4 5 years. So it would have been good. But I think, as you said, Manoj, such a study should be undertaken in India for us to understand
Yes.
what our
Yeah.
bugs are, what our practices are, and whether that is actually in a setting like ours, can we reduce the duration of antibiotics and improve the morbidity status of it? I think it's a good idea.
Maybe
We
you
should
can roll
actually,
out 2 weeks down the line, actually, and on Hicks when we meet. You can roll out such a trial in Hicks.
yeah, it is one idea you have done, so it will be seen in India.
Yeah, yeah.
So would including more parameters would have made more difference in this study, sir, comparatively, because they could not establish any non-superiority of the study also.
So my concern, Navina, as we discussed in Anakin Health study long back in December or January, if you look at a non-representative respiratory specimen like an endotracheal tube aspirate, you may be over-diagnosing tracheobronchitis. And,
True.
and you typically know that patients with tracheobronchitis are not very sick. They have fever, they have a leukocytosis, they have a positive culture, but they don't have a change in compliance, they don't have change in oxygenation, and they don't develop septic shock. Now, if you treat them all as VAP and then say shorter duration of therapy, they won't die. They're not supposed to die. Right. So my concern is, have we included a significant percentage of VAT patients in this diagnosis of VAT? So if you can stratify patients in whom there were no changes in compliance, there was no change in PF ratio, there was no increase in ventilation setting, there were no new infections. In such patients, I have de-escalated the therapy from 5 days to 3 days, and I've shown that there is no increase in the adverse effects. I'm happy to accept that this has a bearing on that. That is one confounder. Are we including VAT in the diagnosis? If you are using only a respiratory tract specimen for the diagnosis, I'm afraid you may be including a good number of VAT patients.
So would you change your practice with this trial, sir? And if so, how short would you think is the short?
Going back, if I go back to the ICU tomorrow and I find a surgical patient who is hemodynamically stable, who has no other comorbidities, which were the exclusion criteria in the study, and who's got a blood drug resistant but no hemodynamic instability, I will consider this.
Manoj, sir, what
But
about you?
that kind of inclusion
So,
criteria
same
looks like
here.
an ad on shadi.com or something.
Add on to what he said, few patients worth mentioning, like viral ARDS, if you have a very good infection protocol and they are anticipated to be on the long time for vent, we will definitely de-escalate after 5 to 7 days. This definitely is a good trial to follow it at the bedside, provided your, as he said, IC practices are very well taken care. Apart from surgical patients, these are the ones, the neuro patients who just get intubated in the ER, and they are just expected to be for a long time on one of the gadgets like T-tube or anything else. The COPD patients, we know it's inflammatory storm. These are the ones where after this trial, I would be tempted to actually rethink after day 5, which may change the practice which we do.
Most of the patients in this trial, like about 80% or plus, were surgical patients. Would you extrapolate this data to the medical ICUs that we see? We don't see so many surgical patients unless, we see the septic shock where the source needs to be controlled.
No,
Yes.
no, we should not.
We should not, but only the things which I said, the neuro patients who don't need more antibiotics, the patients of viral ARDS who don't need, they just need proning / whatever you do for lung protective ventilator strategy. Third ones are the ones I told, COPD, they're always colonized. You don't need a longer course.
So most of our teams, Navina, if you agree, most of our teams look after multiple ICUs, right? We look after surgical ICUs, we look after trauma ICUs, we look after neuro ICUs, and also the medical ICUs. So in one of your ICUs, you can actually use this. There is no harm. But don't extrapolate it into your post cardiac surgery patient and then end up with your cardiac surgeon throwing it out. Don't do it.
I think a few years back, so there was a trial on abdominal infections where a study showed that the antibiotics for 3 days was as good as the usual care.
Provided your source control is good, absolute, and calm.
Yes, but that didn't really actually, we don't really practice it at 3 days for the abdominal infections as such. So would this still be in the pipeline for the same way?
Yeah, I think what we do is we read these studies and then we go back to the bedside and say, in my experience, I think 5 days is good enough. We don't have any number, we don't have any guidance to say that 5 days is gold standard, but we do it. But you need to understand, you need to look at the pros and cons, the exclusion criteria. If you can understand, remember, and bring it to the bedside for everything, I think you can follow some of this.
I totally agree with Dr. Purvi's last slide, which says one size does not fit all. So definitely we have to probably really customize with different patients. But I'm not sure if we can really stop the antibiotics at 3 days. 5 days probably really sounds little more practical comparatively.
It's not practical, Navina. It is comforting to the physician who writes. It is the physician's comfort. It is neither the patient's comfort nor anybody else's comfort. It is the physician is comfortable writing for 5 days, so we are accepting. But as you said, it is not about one size fitting all. The current mantra in intensive care is less is more. So if you use that if you extrapolate that philosophy, this fits into one of the criteria of less is more in intensive.
Another thing is that this trial was actually meant for decreasing the antibiotic stewardship and decreasing the resistance patterns in the microorganisms. But there was no data collected which would support this resistance patterns. They did not see if their resistant patterns actually really help them or not with the short course of antibiotics. So would there be any suggestions? What else
there is a
they could have
suggestion
said?
you and Urvi should write to the editor and the author, and maybe they will give you the answer in the next coming editions. You both should write.
Given the fact that they have their VAP rates are so high, I'm sure the resistance patterns also will do equally well.
But what would they should check actually to actually see the resistant patterns are better with this? What parameters should be included?
So molecular diagnostics should be the method in which they should understand genomics. You look at the microbiological genomics and see which of them are CARBA-R producers, how many of them are OXA producers before and after. That will tell you whether the resistance is actually regressing because of lesser exposure to the high-end antibiotics.
In a resource poor setting, I don't know if there'll be availability of the molecular diagnostics, sir.
So what should be done is different. What can be done is different.
Suggestion.
Dr. Purvi, you want to ask anything?
No, I think everything was being well covered. Even the doubts that, as you rightly said, that they should have included according to the culture-directed therapy, that which organisms would be they encountered had required long course versus short course. Very good input from. Am I audible?
Yes.
Yes.
Yes, the inputs were very good. I had a learning point that, as sir said rightly, Srinivas sir, that along with the clinical features, also other molecular markers should have been studied. And as Manoj sir said, that yes, we could take the data for this trial for the neurological patients and the surgical patients who are preemptively placed on ventilator and not who were previously infected with ARDS. So either for those patients, we can use short course rather than the long course. But all one need to be on the bedside and decide before deciding whether it should be short course or long course, depending on the patient's clinical conditions.
So if we had to redesign this trial and do it in our country, even though our VAP rates are not as much, how would we exclude the patients with colonizing pathogens and VAT?
So my inclusion criteria, Navina, for this kind of a study would be a change in oxygenation and a decrease in lung compliance, along with all the other parameters like a fever, leukocytosis, increased food and load. This will be the only the population whom I will include. I will not include those patients who are oxygenation-wise, ventilator-wise stable, and then apply this philosophy and say my results are good. First point. Second, in centers where there is availability of molecular diagnostics and genomics, I would use it because that is we have it. We have it. Most okay, Thailand and other countries may not have it, but we have it. So we can actually design it in that way. And I would bring it into medical ICU patients. Your hyperosmolar state with your poisoning patients, your other medical patients who come into the ICU, your cardiac failure patients, your COPD exacerbations. I would include them in this.
Do you agree to stop the antibiotics only based on the clinical parameters and not checking any lab parameters like TLC or a procalcitonin?
I am somebody who doesn't believe in treating numbers. So if the patient is getting better, if the patient is febrile, his lung is getting better, his oxygen requirements are coming down, his compliance has got better. I have no business to be tinkering with antibiotics just because there is a 1,000 increase in white cell count or procalcitonin has risen by 20 points.
Your view, sir, Manoj sir?
My view is that the inclusion criteria I will also add in the era of this resistance, those who have used a combination therapy for VAP. So that will also be one of good inclusion criteria if you think about it. In terms of de-escalation, I think I'll go with clinical and WBC count rather than a procalcitonin, because procalcitonin definitely takes a lot of cost from the patient. We still would like to save cost because we are trying to stop the antibiotics. And I think clinical judgment for VAP, me being a pulmonologist as well, I will go by pulmonary auscultation criteria, clinical criteria, oxygenation criteria more than any only procalcitonin as a guide. I will not use procalcitonin.
So your closing comments?
Good trial with some positives, little bit of negatives. The philosophy has to be understood and can be extrapolated into designing much larger trials originating from India.
Yeah, my closing comments, good trial to actually look and introspect what we are doing and will serve as a benchmark for future trial done in settings which are resource limited. Few additions, as we discussed, should be definitely given to the authors by one of us. I think we should do that.
I think it's not just about resource limited, but even though we have resources, doesn't mean really that we need to use procalcitonin and other things to stop the antibiotics.
Yes, yes. Okay.
Thank you, sir. Thank you, Dr. Purvi. Thank you, Srinivas, sir. We'll meet next month with a new trial.
Thank you so much.
Navina.
Thank you.
Thank you, Dr.
Thank
Urvi
you.
and Dr. Manoj.
Thank you.
Excellent presentation. Thank you.
Thank you so much.
Thank you.